Welcome to the deep dive. Today we're plunging into a topic that's fundamental for any plastic surgery resident. Common hand fractures and dislocations.
Yeah, definitely bread and butter
Yeah,
style.
exactly. But we're going beyond just the what. We want to uncover the how and why that truly matters in your daily practice. Our source is a comprehensive review from Plastic and Reconstructive Surgery by Jones, Jupiter, and Lalonde. It's really a goldmine of practical insights. So our mission here is to extract the most vital nuggets for surgical decision-making, patient management, and of course those critical pearls for your board prep.
And what's truly fascinating here, I think, and often the core challenge, is that treating these hand fractures isn't merely about, getting the bone to heal.
Right.
It's really about restoring a full range of wrist and non-scissoring finger motion. That's the ultimate goal. And the path to that goal, which is consistently highlighted in our source material, it's a delicate balance. You're trying to achieve solid fracture reduction while minimizing dissection to preserve those crucial soft tissues and, critically, embracing early protected movement.
That early movement piece is key.
Absolutely. And that approach fundamentally shapes, well, pretty much every treatment decision you'll make.
Absolutely. So let's start with a foundational principle, something maybe easily overlooked. The vast majority of metacarpal and phalangeal fractures are actually managed non-operatively.
That's true. Most don't need surgery.
Which then begs the question for you in practice, when do you have to step in surgically? What are those undeniable red flags?
Yeah, that's the critical distinction, isn't it? You're looking
Yeah.
for clear indications, things like irreducible fractures, obviously open fractures,
Okay.
those with associated significant soft tissue injuries, segmental bone loss, or multiple fractures happening at once. And crucially, you've got intra-articular fractures to watch out for, and malrotated fractures, the ones causing scissoring that you just can't correct with closed reduction. Those demand intervention.
Those are your clear signals then.
Right. These are your clear signals for operative treatment. And for residents, mastering your array of treatment options is so important. Everything from simple buddy taping and closed reduction with immobilization, all the way up to percutaneous K-wires and OR-REF open reduction internal fixation with screws or plates.
You need the whole toolkit.
Exactly. Knowing all the options is key to tailoring the right path to full function for that specific patient.
That's a crucial roadmap.
Cool.
And here's where it gets really interesting, connecting back to that core principle of function you mentioned. The source really leans into the benefits of early protected movement, especially for K-wire fixated finger fractures. They even draw a parallel to the rehab protocols we use for flexor tendon repairs.
Which is quite telling, actually.
It really is. It's a powerful insight, suggesting this early controlled motion isn't just, beneficial for good results, but actively prevents that dreaded stiffness.
Yes, stiffness is the enemy after these injuries.
It absolutely can be a patient's worst enemy.
All right, let's put these principles to the test with some specific injuries. Where better to start than with the thumb? Often a source of real challenge with fractures like the Bennett fracture at its metacarpal base. Can you describe that classic injury for us?
Yeah, the Bennett is a classic two-part fracture dislocation. What you see is the entire thumb metacarpal subluxating dorsally, radially, and proximally.
Okay.
And this distinct pattern, it's primarily driven by the strong pull of the abductor pollicis longus, the APL tendon.
Right, the APL pulling it off course. And when you're faced with one, what's the decision-making process? How do you decide whether to intervene?
Well, if the articular fragment is small, say less than about 20% of the surface, or if you can achieve and maintain a stable reduction through closed means, then closed reduction with percutaneous K-wire fixation is generally preferred. The technique usually involves longitudinal traction, adduction, and pronation, all done under fluoro, naturally. Then you K-wire the metacarpal base either to the index metacarpal or maybe the trapezium. And those pins stay in for how long?
Typically about 4 weeks. But if you attempt closed reduction and you're left with an articular step-off greater than 2 millimeters, well, then you need to go to ORIF.
Open it up.
Yep. Often using a Wagner incision and then small lag screws, maybe 2.4 or 2.0 millimeter, or K-wires. And for board prep, it's worth knowing that studies generally show better long-term outcomes with less than 1 millimeter of articular step-off after your reduction.
Good pearl.
But here's an interesting nuance. Right? One study mentioned in the source actually found little symptomatic arthritis after non-operative treatment for some cases.
Huh. Really?
Yeah, it highlights some ongoing debate and reminds us that, patient-reported outcomes don't always perfectly mirror what we see on the X-ray.
That's an excellent point about the nuance and sometimes the disconnect between imaging and symptoms. Now let's flip to the other side of the hand. The reverse or baby Bennett fracture of the small finger metacarpal base. Similar mechanics, different finger, right?
Precisely. Like its thumb counterpart, the entire small finger metacarpal subluxates proximally and dorsally.
Wow.
But this time, the main culprit is the extensor carpi ulnaris, the ECU tendon.
ECU instead of APL. Got it.
Right. For treatment, the goal is always the same. Anatomical articular congruity. Get that drain surface lined up. So you'll attempt closed reduction with percutaneous K-wire fixation first. That involves longitudinal traction on the small finger, putting dorsal pressure on the metacarpal base, maybe some passive wrist extension, and then pinning it under fluoro.
And if that fails? Or if it's an old injury?
Yeah, if closed reduction fails, or if there's delayed presentation, multiple CMC joint fracture dislocations, or maybe an associated hamate fracture, then ORIF is indicated, often using oblique K-wires or sometimes intramedullary K-wires.
Okay, let's broaden our view now to metacarpal shaft fractures. You see all sorts of geometries here, transverse, oblique, spiral, comminuted. What's the key takeaway about their angulation and the forces involved?
The critical insight here, and something maybe often missed in the rush, is why those angulation tolerances differ so much between the index and middle fingers versus the ring and small fingers.
Ah, yeah. Why is that?
It's all about the innate carpometacarpal, or CMC, joint mobility. It's just a design feature of the hand. The ulnar side, the ring, and small finger CMCs have much more motion,
I see.
which allows that side of the hand to compensate far more effectively for some degree of apex dorsal angulation. Transverse shaft fractures typically show that apex dorsal angulation mainly due to the pull of the interosseous muscles.
Right.
Now, for board prep, you definitely need to remember the acceptable apex dorsal angulation. Only 10 degrees in the index and middle fingers.
Very little tolerance there.
Exactly. But up to 20 degrees in the ring finger, and maybe even 30 degrees in the small finger. Most of these are actually stable after closed reduction and won't need fixation.
Okay. And what about immobilization?
Key patient management pearl. Immobilization should really not exceed 3 weeks. Any longer, and you're significantly increasing the risk of stiffness.
Good to know. So when does that calculation change? When do you need to fix them operatively?
Well, unstable fractures need fixation. Percutaneous fixation is often sufficient, maybe a single K-wire, or transverse K-wiring if it's a border digit, or that bouquet arrangement of multiple intramedullary K-wires pushed up the shaft.
The bouquet technique.
Yeah. ORIF, though, is indicated for a broader range of situations. Failed closed reduction, significant displacement or angulation beyond those tolerances we just talked about, any residual rotational malalignment causing scissoring of the fingers, multiple metacarpal fractures, open fractures, or sigmoidal bone loss.
Makes sense. Any specific technique pearls for ORIF here?
Sure. Longitudinal intramedullary K-wires can be great, especially if you have multiple transverse fractures, maybe in an open injury setting. Dorsal plating is also very common, low-profile 2.7 or 2.4 millimeter plates, making sure you get at least 4 cortices of fixation, 2 proximal and 2 distal to the fracture. And for those spiral or long oblique fractures, lag screws are excellent.
Yeah.
But you need meticulous technique. Precise screw placement is critical, and the fracture length really needs to be at least twice the bone's diameter to avoid fragmentation when you tighten the screw.
Right. Got to prevent making things worse.
Absolutely.
Okay. Moving distally now to metacarpal neck fractures. This is often the classic boxer's fracture, usually in the ring and small fingers. Seems like there's a lot of debate here about what angulation is acceptable.
Oh, indeed. There's significant debate. The functional takeaway, though, goes back to that CMC joint motion.
Right, the compensation ability.
Exactly. The ring and small finger metacarpals have that significant CMC motion, allowing them to compensate for more apex dorsal angulation. Some surgeons tolerate up to 40, maybe even 70 degrees for the small finger neck, although others prefer to keep it under 30.
Big range.
It is. But the index and middle fingers have minimal CMC motion, so any angulation there greater than maybe 10-15 degrees usually warrants reduction.
Okay. Is there a clinical test for that?
Yes. A useful clinical assessment pearl is the pseudo-clawing test. You ask the patient to try and extend their fingers. If you see MP joint hyperextension and PIP joint flexion, that signals significant angulation needing attention.
Pseudo-clawing. Good one to remember.
And for board prep, there's actually a recent level I evidence study that supports immobilizing boxer's fractures with the MP joints in extension.
Oh, interesting. Not flexion.
Right. It challenges the historical practice of putting them in 90 degrees of MP flexion, the old intrinsic plus position. So practice is potentially shifting there based on better evidence.
Good update. All right, let's shift our focus now to the even more delicate structures of the phalanges. Precision here is absolutely paramount, isn't it?
It really is. Small errors can lead to big functional deficits.
So what factors really impact a patient's range of motion recovery after a phalanx fracture?
Yeah, there are a few key factors, and they're definitely board prep gold. First, patient age older patients generally fare worse.
Okay.
Second, interarticular fractures just inherently carry a poorer prognosis for motion.
Makes sense.
And third, crucially, is prolonged immobilization. The data is pretty clear. Less than 4 weeks of immobilization generally leads to about 80% motion recovery.
Right.
But if you go over 4 weeks, that drops significantly, down to maybe 66%.
Wow, big difference.
It is, and it strongly reinforces that core principle we keep coming back to. Early protected movement is vital, especially for those K-wire fixated fractures. Think of it like rehabbing a flexor tendon repair.
That's a great analogy. So let's detail phalanx shaft fractures. How do you manage those based on stability?
Okay, so if you have a non-displaced, stable fracture, it can often just be buddy taped to the adjacent finger.
It's simple enough.
Yeah, and you can allow immediate, gentle, active ROM if pain allows. If there's more pain or some instability, then you splint, typically in the position of safety.
Remind us what that is again.
That's MP joint flexed about 70 degrees, and the PIP and DIP joints held in full extension. But again, for no more than 3 weeks to avoid contracture.
Got it. 3-week rule.
Right. Now, for displaced proximal phalanx fractures, closed reduction involves longitudinal traction, flexing the MP joint to relax the intrinsics, and correcting any angulation or rotation. If the reduction is lost, you have to consider percutaneous K-wire fixation, usually 2 or 3 small K-wires.
Okay. What about middle phalanx fractures?
For middle phalanx fractures, closed reduction is often done by flexing the PIP and DIP joints to 90 degrees. Cross K-wires are frequently used for fixation here.
And if closed reduction fails for either proximal or middle phalanx, or IF?
Correct. If closed reduction fails, ORIF is needed. For long, oblique, and spiral fractures, the goal is anatomical reduction, getting those fragments keyed in perfectly, and then using lag screws, usually 2.0 or 1.5 millimeter.
And transverse fractures?
For transverse fractures, low-profile metaplates are an option. Lateral placement on the phalanx is generally preferred to try and avoid interfering with the extensor tendon gliding over the top.
Makes sense. And what about K-wires versus plates? Is one better?
Ah, the eternal debate. K-wires avoid the more extensive dissection needed for plating. But honestly, many studies show no significant difference in the final outcome between the two techniques when done well.
Interesting. So technique matters most.
Pretty much.
Now, diving into condylar fractures of the proximal and middle phalanges, what makes these particularly challenging? You mentioned intra-articular having a poorer prognosis.
Yeah, these are tough because they are inherently unstable involving the joint surface. That's where the difficulty lies.
So how do you manage them?
Well, for a truly non-displaced unicondylar fracture, if you decide to go non-operative with splinting, mandatory weekly radiographic follow-up is absolutely critical. It's a key patient management pearl. You have to catch any subtle displacement early.
Okay. Weekly x-rays, non-negotiable.
Absolutely. If the fracture is displaced, you need to attempt closed reduction and percutaneous fixation, usually with K-wires or maybe 1.3 or 1.5 millimeter meniscrews. But a critical caution here. These are tiny, delicate bone fragments. Applying large forces during closed reduction can easily cause irreparable comminution or damage to the articular surface.
Be gentle.
Gentle hands needed.
Definitely. If ORIF is required, the surgical approach is critical. You need to preserve the central slip insertion and the collateral ligaments attached to that condylar fragment at all costs. Don't strip it.
Preserve the attachments.
Exactly. After you get an anatomical reduction under direct vision, fixation is usually with parallel transverse K-wires or maybe lag screws. Post-op early ROM can be started carefully, but typically the PIP joint is splinted in extension for a period to prevent that common complication of extensor lag.
Okay. And briefly, what about intra-articular fractures of the base of the middle phalanx, the ones often related to volar PIP joint dislocations? Right. If it's a non-displaced avulsion fracture, perhaps of the central slip insertion dorsally or the volar plate attachment, you treat it by immobilizing the PIP joint in full extension. If it's displaced, meaning more than about 2 millimeters, it generally requires reduction and fixation, often with temporary pinning of the PIP joint in extension for about 3 weeks.
Got it. Let's shift gears now to some more complex dislocations and associated ligamentous injuries, starting with dorsal proximal interphalangeal, or PIP, joint dislocations.
Okay, a really crucial piece of advice here. for residents managing these. Most simple dorsal PIP dislocations are non-operative. Reduce them, check stability, but avoid prolonged immobilization at all costs,
Why is that so critical?
because it almost inevitably leads to permanent stiffness or a flexion contracture at the PIP joint, which can be incredibly debilitating for the patient.
Right, function again.
Always function. Live fluoroscopy during the reduction and stability check can be very helpful here if you have access.
Good tip. So what's the typical treatment then?
Reduce swelling, buddy take the injured finger to its neighbor, and initiate active range of motion exercises early. And counsel patients. Tell them that stiffness and swelling can honestly persist for up to a year, even with a simple dislocation. Manage expectations.
Okay. What if it's a fracture dislocation but seems stable after reduction? Maybe a small volar lip fracture.
Right. For those stable fracture dislocations, typically defined as less than about 40% of the articular surface being avulsed, the standard treatment is 3 weeks of dorsal block splinting.
Explain that splint again.
Sure. After you confirm a concentric reduction with a good true lateral radiograph, you apply a dorsal splint that holds the PIP joint in about 30 degrees of flexion. This prevents full extension, which is the position of instability.
Okay.
The patient can actively flex the finger within the splint, but the splint blocks that last bit of extension or hyperextension.
And monitoring.
Another key monitoring pearl. As you progressively extend the splint over those 3 weeks, maybe 10-15 degrees per wink, you must obtain weekly, true lateral radiographs.
Weekly x-rays again?
Yes. To confirm that the joint remains reduced as you allow more extension. If it starts to subluxate, you need to change your plan.
That weekly check sounds absolutely critical. Now, let's address the really complex ones. Unstable fracture dislocations of the PIP joint, especially those with a large volar fragment, say greater than 40%. You hear lots of different approaches here.
Yeah, this is where treatment consensus is often lacking, and it becomes quite challenging. There's a diverse array of options.
Like what?
Well, one option is an extension block pin. A small K-wire placed dorsally into the proximal phalanx head can block dorsal subluxation while still allowing gentle flexion and extension up to the block. The advantage is it might avoid the scarring from an open reduction.
Interesting. What else?
For significantly comminuted fractures or pylon-type injuries of the middle phalanx base, dynamic skeletal traction devices can be really valuable. Things like the Schenck device or the AG joint jack.
How do those work?
They rely on ligamentotaxis, basically using the intact collateral ligaments under tension to pull the fragments into better alignment and maintain joint space while allowing early active ROM.
Clever. What about fixing the fragments directly?
If you have a single large volar fragment, ORFF with small K-wires, or perhaps a lag screw can be done, followed by early ROM. But if that volar fragment is too comminuted and just not amenable to ORFF,
Then what?
then you might consider a volar plate arthroplasty. This basically uses the patient's own volar plate to resurface the damaged base of the middle phalanx and act as a buttress to prevent resubluxation.
Wow, reconstructing the joint surface.
Exactly. It involves advancing the volar plate into a prepared groove in the middle phalanx base and securing it. Newer approaches also include using a heminemet autograft, a piece of bone from the hemet, to restore that volar buttress.
Complex stuff. Okay, bringing us towards the end here with a final but very critical ligamentous injury. Ulnar collateral ligament, or UCL, injuries of the thumb, metacarpophalangeal, or MCP, joint, the classic skier's thumb.
Yes, an injury you will definitely see, often caused by a forced abduction of the thumb, like falling on a ski pole.
So what's the absolute key point for residents to understand about this injury?
The Steiner lesion. This is the critical concept. You have to know this.
Okay, emphasize that. What is it?
In about 2/3 of complete UCL ruptures, the torn proximal end of the ligament gets flipped superficial to the adductor aponeurosis, this broad tendon structure on top.
Flipped out of place.
Exactly. And because it's displaced like that, with the adductor tendon interposed between the torn ligament end and its insertion site on the proximal phalanx, it simply cannot heal with non-operative treatment, like cast immobilization.
Ah, so it's blocked from healing.
Precisely. Which means a Steiner lesion is an absolute indication for surgery. You must fix it.
Got it. Absolute surgical indication. How do you diagnose it? Can you tell clinically?
You can often get a strong suspicion clinically. You need to distinguish partial from complete tears. Complete tears typically have significant laxity on radial stress testing, maybe more than 35 or 45 degrees, or at least 15 degrees more laxity than the uninjured thumb. And crucially, there's no discrete endpoint when you apply that radial stress under a good local anesthetic block. It just feels mushy.
No firm stop.
Right. Imaging like ultrasound or MRI can also be very helpful in confirming a Steiner lesion if the clinical exam is equivocal.
Okay. So when do you operate and when can you treat non-operatively?
Well, if a Steiner lesion is definitively ruled out either clinically or by imaging, or if it's clearly just a partial rupture, then non-operative treatment is appropriate. Usually a thumb spica cast for about 4 to 6 weeks. Small, undisplaced avulsion fractures associated with the ligament can sometimes also be treated non-operatively if the joint is stable.
But if you suspend or confirm a Steiner,
Then surgery is needed, or if there's a significantly displaced avulsion fracture, say greater than 2 millimeters.
and the surgical technique, briefly.
Typically an S-shaped incision over the ulnar aspect of the MCP joint. If a Steiner lesion is present, you need to identify and carefully incise the adductor aponeurosis to find that retracted ligament end and bring it back down to bone.
Okay.
Repair depends on the tear type. Mid-substance tears might be repaired with sutures. Avulsions from bone usually require reattachment with either pull-out sutures through bone tunnels or, more commonly now, small bone anchors. You should also check and repair the volar plate attachment and any dorsal capsule tears. Then test the repair stability gently.
Do you pin the joint?
Sometimes.
Yeah.
Pinning the MCP joint with a K-wire and slight flexion is usually done only if there's some residual laxity after the repair. Post-op, it's typically a thumb spica splint, keeping the IP joint free for about 4 weeks.
Wow, that was indeed a comprehensive deep dive into the real nuances of hand fractures and dislocations. We've covered a huge amount, from general principles right down to specific surgical techniques and those critical patient management strategies, all drawn from our source. So what does this all mean for you, the listener? Hopefully it's clear it's about much more than just memorizing facts for the boards. It's about having that clinical wisdom to guide your surgical decision-making, manage your patients effectively, and really understand the why behind each choice you make.
Yeah, and it really raises an important question for all of us in practice to consider, doesn't it? Given the varied and sometimes, as we discuss, contradictory long-term outcomes, particularly for those tricky intra-articular fractures, what truly defines a successful outcome for each individual patient?
Good question.
Is it always achieving perfect anatomical restoration on an X-ray? Or is it more about achieving their specific functional goals and ensuring patient satisfaction, even if there might be some residual radiographic findings? It's a balance we constantly have to strike in hand surgery.
That's a fantastic thought to end on. A great reminder that patient-centered care, focusing on their function and satisfaction, is always the ultimate goal. Thank you so much for joining us on this deep dive. Go forth and apply these principles and that thoughtful approach to the next hand fracture you encounter.